Hi everyone. Hi everyone. Today we're going to do section D. The overall objective of the wheelchair assessment is to describe the patient's medical condition and limitations and therefore justify the intervention. In simple terms, when writing a letter of medical necessity, Medicare may request the assessment of the patient's limitations that the justification has been based on. For example, if you're writing a beautiful letter of medical necessity and there's no actual objective measurements or anything that shows where you've actually collected the objective information about the patient, Medicare would say, beautiful letter, where's your evaluation, your assessment, where is this information coming from? So what we've been able to do here with DocuSign, we're able to provide a seating mobility evaluation, which is an assessment with a built-in letter of medical necessity. By recommending and justifying the intervention where the limitation is assessed. Example, by trunk and pelvis, after indicating the patient's kyphosis, the comment section recommend contoured back. That's the intervention to accommodate the patient's kyphosis. So what we're basically doing is going through the patient's skeletal, showing how the patient presents, assessing how they present, and therefore writing, therefore the patient requires X, Y, and Z accessory or seating function, and that's how we justify it right off the assessment, build an assessment, letter of medical necessity, all built in one, while the therapist is working with the patient. This has been a fantastic and very efficient system. Let's go through the DocuSign items in the DocuSign seating mobility evaluation. Each aspect of the assessment may be a reason to justify and recommend the chair, the seating, and the accessories. So I'm going to open up an email here. This is what it looks like when you get it from a facility. I'm acting here as the actual therapist. Silverchair sent me a seating mobility evaluation. I'm opening up Review My Document. I'm now logging in as a clinician. This is what the clinician looks like when they're opening it. So just so you understand how it works on their end. So this information has already been populated. The date, it's patient's Jane Doe. Whatever's red means it must be filled out. So we're going to give this patient a weight of 156 pounds. Reason for referral, very important. We're putting in power wheelchair patient. Now this is called conditional logic. It's editable and it must be edited. This is not something we're allowed to populate for the. This is not something that can automatically just be in there for the clinician to have. We're not scribing it. It's based on the power wheelchair assessment that you're selecting. We now have a patient background. It must be edited to make sure it fits the patient that we're discussing. So power wheelchair evaluation, patient with medical diagnosis of. So we know this patient that's up here has a CVA, hemiplegia, limited endurance. Okay, it's unable to get around home for ADL care, as in getting from the bed to the kitchen for meals. Patient's unable to use a cane or walker, as patient is a high fall risk. If the patient was non-ambulatory or non-weight bearing, I'd change that to right non-weight bearing. Patient unable to self-propel a manual wheelchair at all when trialed due to poor trunk control. Limited endurance, impaired coordination. Does that all make sense? For this patient is unable to safely transfer on-off scooter. Patient requires a power wheelchair for independent mobility with ADL care. Patient is able and willing to operate a power wheelchair. So this is, we give ourselves the patient medical diagnoses, the background, the ADLs, and we just eliminated the less expensive equipment, the cane, walker, manual wheelchair, and scooter. So this box right here, we kind of get a lot of our goals taken care of. Now, what are our patient goals? Do we want independent mobility or dependent? We're looking for independent because it's a motorized wheelchair patient. There's always going to be boxes here. This is an optional box. If the patient has other goals also, wants to go back to work, wants to understand, whatever going on with your patient, if you have anything more specific you want to add, you have optional sections, all right? These are also optional for the clinician, physician, RTS. Sometimes this comes pre-populated. Cognitive status, within function, behavioral concerns are none. Communication skills is, let's say write delay. I want to write over here, does not affect ability, memory skills. Option, vision is intact, hearing is intact. If there was an issue, let's say communication delay does not affect patient ability to operate our wheelchair. If you're ever writing some sort of delay or any sort of deficit, we need to then attest that it does not affect. Patient may have impaired vision, but they use glasses or they can still get around. Their hearing is not so great. As long as it's not affecting their ability to be safe in the wheelchair, we want to address it there. Dressing, mod assist, grooming, mod assist. You can write some comments here. Let's say mod assist for mod for upper and max for lower. Anything like that. Meal prep, it could be max or total dependent. Has 8 for meals. Home management, same concept. Administration, probably mod assist. Scroll down. Toileting, independent or assisted. At least you have a catheter. All this sort of stuff we can add in the comment section. Ambulation, non-ambulatory. We can also select over here high fall risk or inability to initiate gait, cane walker not safe. Either way, we want to go into the comments and eliminate the cane or walker. What we could also do is, depending on their patient, I have this patient here who's a stroke, hemiplegic, inability to initiate gait, cane walker not safe. You can also add more in the comments. You can select the drop down because they're pre-printed and they're easier. They might fit your patient. If they don't select it and go to the comments. Wheelchair transfers, he is a max, and you can, over here we're going to select the power elevating seat. This is a new feature that Medicare recently started paying for. It allows the chair to go up and down 12 inches. We can recommend it right now. Manual propulsion, we wrote unable, and now write comments. You need to write another self-propelled at all when trialed, 5 feet, 10 feet. Medicare wants to know what happened when this was trialed. They can't just say, oh, patient can't do a manual wheelchair. Unless they have no arms or no legs. If they have arms and legs, they want to know what happened when they trialed it. Operate power wheelchair, we're going to write yes. And this box over here, if the patient needed upgrade electronics like a head array, or they needed sip and puff or micro extremity controls, anything like that, we put that over here. If the patient had some sort of cognitive deficits, you wanted to elaborate more about in the comments why it works, that's great. If you also want to help identify right hand or left hand, it's a good section to write right hand joystick. So we have it documented in the evaluation. Oops. What type of joystick and what side it should be mounted on. Risk of skin breakdown. This is the patient I'm going to write as high because their max for transfers we wrote up here. Skin history is no. Sensation status is impaired. And then mechanical assist. This goes through how are we going to be doing the wheelchair. How are we going to be doing weight shifting? So we're going to put power, tilt, and recline. And again, we have another conditional logic here that pre-populates. This logic is great. It definitely helps you lead on to where to go with it, but it needs to be edited. It has to be gone through and make sure it matches this patient. It's all editable. It's a red box, means it has to be written out. Patient at high risk of developing pressure ulcers. This patient does not have a history of ulcers, so we're going to delete that. Due to his inability to perform an effective upper body weight shift, secondary to status code CVA, resulting in weakness and is max for all transfers. Patient requires power and power recline seating system to facilitate pressure relieving activities. Optimally redistribute weight with power tilt and power recline combination. and increased seating tolerance. Part of why we got, just to harp again on the power tilt and recline, because there is a study at a University of Pitt saying that if a patient was to use tilt only, they would need to go to 100 and they need to go 45 degrees back for a tilt. If they go to recline, they need to go to 150 degrees of recline. Most patients are not pushing back that far, either in tilt or recline, consistently to get that pressure relief. But they have found that if a patient would go to only 15 degrees of tilt and 120 degrees of recline, which is not that much tilt or that much recline, they reposition themselves like that in the combination, they have found it to be the optimal redistribution of weight. So we want our patients to be optimally redistributing our weight, and Medicare recognizes this as a justification because we're giving this chair to prevent patients from either developing pressure ulcers or patients that have pressure ulcers from helping them heal. We want to make sure it's actually going to work for the patient. So if the patient ever needs a tilt, 9 out of 10 times we're pushing for the power tilt recline because that is the optimal redistribution, and that'll also improve the patient's seating tolerance. You can picture someone sitting in a tilt chair if they're at 90 degrees or 95, 100 degrees, sort of seat to back angle the entire day, and they're just tilting a little back and forth, they're going to get uncomfortable. If they can tilt all the way back, that's great, but the ability to redistribute their weight and mess with their seat back angle throughout the day with the recline is something that will really improve their skin integrity as well as improve their seating tolerance. Current equipment, if the patient has equipment right now, this is an optional box. If they have a standard chair or they have a motorized chair which is broken beyond repair, or the motorized chair is a group 2 captaincy and it cannot accommodate multiple power seating functions, this is where you'd write that. Assessment questions: does your patient have mobility limitation? Yes. Does your patient have, or does your client or their caregiver capable and willing to operate MEH at home? Yes. Can your mobility work with cane and walker? No. Does your client have home environment support? Answer is going to be yes. And we do home assessments. We'll get to that later on. Does your client have an upper right extremity? No. Does your client have the trunk control? No. Now you get the head and neck and head control. If the patient has any limitations, you can put this all in. We always want to give as much objective measurements as possible. So for function, it's going to be limited. This patient has a left hemiplegia. This will be within function. We're going to write limited 0 on the left. Right, he's got 3. Patient requires arm trough to maintain upper extremity support. This is for the left upper extremity since the patient is hemiplegic, and their left arm support will be falling off the chair if it's not wide enough to kind of cradle his arm. We want her arm, this is Jane, so we want to make sure that the patient has a arm trough. Further on comments, this patient, because it's hemiplegia, does qualify for postured seating. Patient requires either contour back with swing weight laterals to maintain midline decreased lean, or contour back required to maintain. We'll give this patient laterals because the hemiplegia, they are totally flaccid on their left side. You want to make sure that they're sitting upright. If we had any additional comments or any additional accessories, we can put that in this section. Pelvis, posture and pressure cushion. This patient does not have any pressure concerns. They have impaired sensation, so we're going to go for a pressure and posture. Cushion required to provide pressure relief and stabilize pelvis. Strength, left hip, we're going to give him a 0, right hip, 3. Requires swing weight thigh guides to maintain lower extremities at neutral. This is the patient is sitting abducted and we're nervous that the left leg will fall off the side of the chair. We want to make sure that although they're in a contoured seat and they're cradled, we want to give them extra support on the side to make sure that their leg doesn't push over the side of the chair and hit a wall or a door. So we're going to put on swing weight thigh guides. The other option here was medial thigh guides. That's for a patient who is adducted and we want to be able to pull the knees apart. Lower extremities, we have requires foot box to maintain lower extremity on foot support. It's for a patient who has limited or no foot control and we're nervous that they'll fall off the foot box. A patient like this who has the left hemiplegia and doesn't have any control of their left side, you want to make sure that their foot stays on the foot support because if their foot's off, they're pulling on their pelvis, they're putting on their entire body. We want to make sure that their feet legs, upper extremities is not messing up their pelvis and keeping them safely in the seat. Again, we're going to go through some functions on the lower extremities. We're going to select what applies to the patient. Any comments regarding the patient's strength, I'll include that over here. Patient requires power elevating leg rest to decrease lower extremity edema. If the patient has lower extremity edema, this is where you mentioned you want to elevate the legs to increase the blood flow and bring down the swelling. Also, for recommending the recline, so whenever a patient goes into recline, you're going to open up their body, they're going to go in kind of a supine, open up their pelvis angle. As soon as their pelvis angle is opening up a little too much, by 120 degrees or so, you want to make sure that you're lifting their legs and they're not sliding out of their chair. So we have para-elevating leg rest required to maintain lower extremity support while in recline. Either one of these can work for this patient. You can do that, and then right over here, power elevating leg rest also required to maintain posture and safety while in recline. Toe movement, normal. If the patient had, this patient more like hypotonicity, but if they were hypertonic, we would then be able to recommend, if they had spasm, patient with, let's say, Parkinson's or something like that, there's a justification. Patient requires power recline to manage tone and maintain range of motion. Patient requires power recline to manage spasticity. Our patient does not have that, so we're going to continue going. Wheelchair recommendations. We'll give this patient a Quickie Q500 MP, and the justification here is independent mobility with ADL care, can't walk or manual wheelchair, and scooter not appropriate. Patient is able and willing to operate a power wheelchair. This is if the patient required a heavy duty. You can add on over here, heavy duty required, very heavy duty for 450 pounds. This patient does not weigh heavy duty. Now, power tilt recline. Accessories, and this is going to come along another conditional logic which must be reviewed and edited. Power tilt recline is going to be power tilt and power recline combination to facilitate pressure relieving activities. Optimally redistribute weight with tilt to increase seating tolerance with tilt and recline to increase seating tolerance with frequent change in position. Headrest with removable bracket to provide posterior head support while in tilt. And recline. We're actually going to give this patient a posture and pressure cushion. Stabilize pelvis, increase pressure distribution, and provide pressure relief. Contoured back required to maintain trunk and midline. We also are giving these swing away laterals to decrease lateral lean. Power elevating leg rest to maintain the body support while in recline and to decrease edema. Delete. Expandable controls, harness multiple actuators to operate and control multiple power seating functions through joystick, power batteries to power motor, joystick mount for safe and easier transfers. The above. Okay, we're also recommended a foot box to maintain low extremity support on foot box to maintain low extremity on low extremity support. But I recommend that a wheelchair will provide the patient with independent mobility and will improve overall quality of life. Patient is able and willing to operate a power wheelchair. Now, what next thing we want to do is we want to, if you had any other accessories you wanted to add on, to some contoured seat, back, posture cushion, adjustable pressure relief, seat cushion, patient requires O2 holder. We have a bit of a drop down here to add that. And any other accessories, I want to put the arm trough in. Arm trough required to maintain left upper extremity on upper extremity support. We also added the thigh guides with swing away brackets required to maintain lower extremity on seat cushion. Not sure what happened here, thigh guides. Do that midline. Then we have the patient's measurements. We'll film what we know over here. 19, seat to elbow. These are the critical ones. Hip width. Not 199. Axilla. I go down here and I sign. Select down here my credentials, so I'll put in PT. Next, I missed something. Tilting. That's odd. It wasn't the toileting, it was the feeding. That's it, I'm done. I can log in here and I can get this stuff, or I can just say I am done with my assessment.